I'm your host, Dr. Bolanle Liman, and today we're going to talk about something that affects every single one of us, dental care, and more specifically, dental care prevention. In today's episode, we're shining a light on one of the most overlooked yet vital parts of our health, oral health. Our guest is Dr. Michael Verber, a visionary leader in dentistry based right here in central Pennsylvania. He joins us to talk about how we can reimagine dental care, moving from a system that focuses on treatment after problems arise to one that prioritizes prevention, education, and access. Some facts to set the stage. Over 74 million Americans have no dental coverage, more than twice the number without medical insurance. Most dental visits still revolve around treatment, fillings, extractions, and crowns, rather than prevention like nutrition counseling, early intervention, and consistent cleanings. But oral health is about more than teeth. It's linked to diabetes, heart disease, pregnancy outcomes, and overall quality of life. In this conversation, Dr. Verber will share his insights on why prevention dental care is both effective and underused, how systemic barriers keep people out of the dental chair, and what changes are needed at both the clinical and policy level to make oral health a priority for all. Whether you're a patient, provider, or policymaker, this episode will challenge you to think differently about the dental care and what it could look like. Please follow us on Instagram, YouTube, or Facebook under Healthy and Helpful Podcasts. Without further ado, it's a pleasure to be joined by Dr. Verber. Good morning, Dr. Verber. It's a pleasure to have you join us today.
Good morning. Thanks for having me.
So let's begin by you telling us a bit about the incredible advancements you've made in dental services in central Pennsylvania.
I don't know how incredible they are. We are a little bit unique, though. So the Verber Dental Group is what we refer to as a dental health system. I think if you kind of look at dentistry, there's two models that exist today that are most common. One is the traditional solo practitioner or small practice model where one or two dentists might be working together. And the other is kind of corporate dentistry, which is kind of interesting. We've seen a lot of investment, a lot of private equity come into the dental space. And that corporate model is, they often are referred to as dental service organizations. And the idea is these DSOs are taking away a lot of the business burden from dentists to allow the dentist to kind of concentrate on the clinical aspects. So they're using these business economies of scale. But the interesting thing is they don't really use clinical economies of scale. They're not working together. You could have one office down the street from another office, part of the same corporation, and they're competing with each other almost by design. Our dental health system has all our offices in one area, and we're thinking about how we can kind of center our services to help the patient. So we have all our specialists, everything from the oral surgeons to the endodontists, the doctors that do the root canals, to our dental lab, to our general dentists, all working together. And we're 100% owned by providers that see patients. So we really try to keep the focus on the patient.
That's important, and I've had the privilege or joy of going to see a number of these different specialists thanks to my children's dental issues, my dental issues. So was it the DSOs that led you to develop this dental health model?
Well, in part, I think my partners and I saw what was coming on the horizon. There's a lot of new technologies that's very expensive and costly that we wanted to provide to our patients. We saw that the economies of scale were real and were a benefit, but there certainly is something missing when it's not a provider-driven type organization. I'm the old man in the organization, so I'm 49 years old. Most of my partners are in their late 30s or early 40s. So we don't have to think about what the quarterly returns are going to be, like an organization that's owned by shareholders. So we could think long-term, we can make long-term investments, we can really be centered on the community.
Thank you. We've seen a number of changes in oral health over the past few years, both here in the US and internationally. So less tooth extractions, for example, but considerably more dental caries and gum disease. Can you tell us a little bit about this ongoing oral health epidemic?
Yeah, I mean, I think the World Health Organization says nearly half of the population suffers from oral disease. And when you think about oral disease, you're thinking about, not just dental caries, cavities, you're thinking about oral cancers, periodontal disease, tooth loss from occlusal disease. Occlusal disease relates to how our mouths come together, how our teeth work. I think it's a confluence of a really severe access to care crisis and a change in environment. So it's interesting, if you were to take a population that's isolated, let's say you were able to take a boat up the Amazon River and find an isolated population, they're not going to have the same dental issues that we have. They don't have the refined sugars. They're breastfeeding longer, which develops the mouth. A lot of times you'll look at our population and you'll see this drastic need for orthodontics, right? Because we have crowded teeth and narrow palates. That is a result of environmental factors and dietary factors and a lack of breastfeeding and these other things. So we get crowded teeth. Our mouths, our machines are out of alignment, like a car whose tires are out of alignment. And that's causing all sorts of problems with periodontal disease because the teeth are taking forces incorrectly with airway stuff. Oral disease is something that we're seeing from tobacco use. We have gotten, oral cancers from tobacco use, vaping. We have taken some steps forward with that, with vaccines for HPV, which has eliminated some of that. But the real big thing is this just lack of dental providers. We've done better with dentists. We have a 28% increase in the amount of dental graduates over the last decade. But there's actually been a decrease in dental hygienists and dental assistants.
That's an interesting fact. Can you tell us what a dental hygienist does, and why do you think there's been a decrease in the number of dental hygienists?
Well, so let's start with what a dental hygienist does. What a dental hygienist does and what they can do are two very different things. And part of the reason I think for that is because we're seeing such a shortage. So a dental hygienist, in my mind, is almost like a primary dental care provider. I think in the minds of a lot of people, even in the industry, they clean teeth, and we have to start to reimagine what that looks like. But the dental hygienist is usually the person that the patient has the closest relationship with. You're coming in every 6 months, ideally, seeing that dental hygienist. They're doing oral cancer screenings. They're doing co-diagnosis. It's not within their scope of practice to diagnose things, but the reality is they're the ones that know what's going on because they have spending the most time with that patient. So that co-diagnosis with the dentist is very important. They're doing the health histories. They can be, a frontline screener for other systemic health issues. The problem is a key to oral health is to have mechanical debridement of plaques in the mouth. And that's backbreaking, very difficult work. And that the dentist needs somebody to do that, and the dental industry needs somebody to do that. So we have these very highly trained individuals doing these very manual, redundant type jobs. So we have a problem on both ends. We don't have enough schools graduating enough dental hygienists, but the people that we are graduating are getting very burnt out and very bored doing this job. So there's even an article that just came out saying, is dental hygiene a 10-year career? So we have more falling out than we have coming in.
Do you have any ideas or solutions to address this?
Oh, I have more. Yes, I have plenty of ideas and solutions. It's probably the execution that's the challenge. So the first thing I think we have to look at is you have to increase the number of schools that we have. And we're making a number of efforts doing that. There's a local school that graduates about 20 hygienists a year. And that school is only accepting about 5% of their applicants because there's so many applicants. It's a great, dental hygiene is a very attractive career for a number of reasons. It's a very well-paying job. The hours are good. I think there's a lot of satisfaction because you're dealing with patients. You're working in a pretty good environment. So we're getting a lot of interest in the careers. If you're only accepting 5%, who are you accepting? You're accepting the most academically, intellectually inclined students. These students have the highest test scores. You're not getting, for example, a lot of the kids that are coming out of the career and technical centers, the VOTECs. They're not getting in. So you have a student in high school that dedicates themselves to dentistry. They're not able to get into dental hygiene school. We're losing those students. The students that get into dental hygiene school are so intelligent, they're getting bored with the dental hygiene career, they're not staying in. So the first thing we need to do is just expand the number of schools, and we need to do that very rapidly and very robustly. Right now we have 1/4 of the number of hygienists we need to service Pennsylvania. I think the second thing we need to do is look at what we can do on the side of the existing hygienists and future hygienists as far as expanding their scope of practice. So there's certain things I think they have accomplished. They're able to work independently in some situations now. And they are also allowed to give local anesthetic. So if a patient needs to be numbed up for a procedure, they can do that. If you look over 100 years of dental hygiene, those are the only two really major changes. Otherwise, they're doing the same thing they did 100 years ago. If you look at what we're doing as dentists, from digital technologies to advancements in care, it's totally different. The way I practice now is different from 5 years ago. So we need to expand their scope of care, empower them, and support them so that they can have more interest. They want to be able to do nitrous oxide, for example. You know, these hygienists are extremely capable. If we give them the proper training in CE, I think we need to allow them to do things like that. But instead, we're having these turf wars between the dentists and the hygienists, and I think the same thing happens in medicine sometimes. I think the other thing we need to do is create a new category of mid-level provider. There is talk of doing things between a hygienist and a dentist, like a dental therapist. Some states have dental therapists that have allowed, and that really helps with the access to care. A lot of dentists are opposed to that. I am in favor of that because I think the public needs it, but I also think it is something that can keep a hygienist engaged and give them something to shoot for to ladder up to. But I think the key is to do something below the hygienist. And where some states are just, because of the crisis we're looking at right now, some states are starting to do that. They might call them a scaling assistant. So in my mind, a dental hygienist would essentially come to work. They would be the primary care provider. They might have 2 scaling assistants working under them with the dentist. And we're taking some of the monotonous, repetitive stuff off of them. And they can focus more on some things like systemic health and integrating, dentistry and medicine and overseeing some of those things, co-diagnosis, where the scaling assistants are kind of doing some of the more repetitive stuff. We have an expanded function dental assistant on the restorative side to help the dentist, and that's been game-changing. And I actually think quality has improved with that.
Mm-hmm. You mentioned the co-diagnosing with a dental hygienist. I think that's very important. And when they co-diagnose, can you share some information on how they educate the patient? And then just as importantly, if there is communication with the primary care provider or subspecialist?
On the medical side?
Yes.
Well, again, I think we have a lot of work to do here where we're integrating and communicating with the medical side. The co-diagnosis on the dental side is really happens, couple of things we do, I think, well in our practice is imaging. So, beyond the x-rays, we're taking intraoral photos. Those photos are put up on the screen. A lot of these things, whether it's a soft tissue lesion that we want to track, or it's a decay or wear on the teeth, fractures in the teeth, or a failing restoration, we want it up on the screen in front of the patient, in front of the hygienist before the doctor comes in. The hygienist isn't going to say that's a cavity. The hygienist they're not allowed to, and maybe unfortunately they're not allowed to, but they're going to say we're going to look at this area. So they're prepping the patient and also keying up the dentist when they walk in to look at that. There's a lot of interesting things with technology now too. So we have AI systems that are basically reading radiographs, which is something that's happening in medicine. So you walk into an exam now as a dentist, and when those radiographs are on the screen, it's going to indicate any areas where there might be bone loss. That's an indication of periodontal disease. It could be indicating areas where there is possible decay. So the hygienist is really kind of prepping the patient before that. It's nice as a dentist because now we're not really the person breaking the bad news. We're almost like the second or third opinion. So the hygienist and the technology do a lot of work. To be frank, we're not communicating as well as we can with the medical side of things. Where that communication does come in is usually when there's surgery needed, right? With some oral surgery, because then we're reaching out and getting the consults and doing all those things. Part of the problem is the economies aren't right. So hygienist salaries have gone up quite a bit, which is a wonderful thing, and they deserve every dollar. The problem is the dental insurance companies have not prioritized preventative care. So the hygiene exam, when that patient walks into our office for a preventative hygiene exam, we know we're going to lose money on that. They're just not reimbursing enough for the cleanings, for the exams, for the x-rays, for us to make money. So, how do we stay in business? Well, when somebody needs a crown or when somebody needs an implant, the dentist, who is usually the one driving a lot of the decisions, are really like in your space, they're the equivalent to the surgeons, right? So your primary care providers or your family medicine docs are more focused on overall medicine. I'm just a surgeon, right? So I'm looking for the problems that I need to fix. If we had and it's really interesting because I've often asked why why the insurances don't prioritize preventive care more. Because you'd think they want to keep the patients out of my chair. But it's something we have to look at. I think it's something that dentistry and hygiene, the different organized, organizations, it's one thing we could probably really work together on is try to change how we think about reimbursing for preventive medicine.
I think one of the other challenges is obviously cost. And so unfortunately, many people might not come to the dentist until there is a problem. Do you have any ideas or suggestions how to address the ongoing concern that prevention is better than cure and routine dental screening when there are ongoing cost issues? Yeah,
so most of my clinical time now is spent at our dental specialty center, at our implant center. So I'm kind of like the end of the line. So I see patients that have lost all their teeth or are losing all their teeth, and they're literally paying out of pocket tens of thousands of dollars to be rehabilitated. And it's very, it's very rewarding for me because, the difference that we're making when they get their dentition back, the way they appreciate that after having to use a denture or whatever is substantial. But it shouldn't have to be that way, right? Most of my patients have one thing in common. They did not have access to dental care when they were younger. So, getting in, first of all, just to prevent some of these problems, right? We all need a coach. We all need a guide that can help us making sure we're taking care of our teeth, both with the home care, but also identifying problems early. If we get a problem early, it's a small filling versus something that turns into a tooth loss later on. But at the end of the day, we just do not have enough providers to do this. So we can charge whatever we want or as little as we want, but if there are not enough providers who don't have enough hours in the day to see our population, it's not going to make a difference. And I'll give you an example. So Sadler, that you're aware of, is a clinic that is an organization similar to Hamilton Health, and they opened a dental clinic on the West Shore near one of our offices. So you go into Sadler. The last time I went in, I took a tour. They have two or three dentists. They don't have a hygienist. So they're not doing any prevention. They did initially have hygienists. They hired 3 hygienists when they opened up. So 2 of those hygienists came from me, which is okay. So I put an ad out. I hired 2 hygienists from different doctors in the area. I'm not targeting anybody, but I put an ad in. They're coming from somewhere, right? So then those 3 hygienists that went to Sadler ended up backfilling the hygienists that I hired from the other dentists. So it's just this shell game where we're moving this limited supply of hygienists around. So the question then becomes, where is the access to care going to be? And it's going to be who's willing to pay the most. So we had, an access to care line, with 2 million Pennsylvanians that have no access to dental care, and that number is growing quite a bit. The access to care line was falling, probably below that private insurance. If you have Medicaid as your dental insurance, you're not seeing a preventive. You're only getting in for a extraction. You're not going to get a cleaning, okay, which is horrible. Now that access to care line has shifted, and it shifted up. We were just talking one of the largest private dental insurances we had to drop our participation with. We had patients, a new patient couldn't get into our offices for 6 months. Some of our existing patients, rather than every 6 months, we were trying to find spots, and the earliest we could get a recall was 9 months. We just couldn't see all the patients, and the salaries and our costs were going up, so that private insurance was not reimbursing us enough to survive. So now all of a sudden that line goes from, well, if you have Medicaid, you don't get a dental cleaning, to if you have this insurance, you don't get a dental cleaning. And that line's going to continue to go up until we turn this around and we start to make more providers or change the scope of practice for people.
And for the audience, Sadler is a federally qualified health center. FQHCs predominantly serve the underserved, and FQHCs generally do an excellent job integrating multiple specialties. So dental is one of them. And that segues well into my next question, is regarding the integration of dental services in primary care. So we know there's a shortage, so ideally, it's challenging to do so, but perhaps your health center or others, has there been any thought into the integration into primary care?
Yeah, I think this is something that is going to start to happen organically. So as we understand more and as we start to tie the connection between oral health to systemic health, we're going to start to see some natural overlap. I think to do a really good job of this, it's going to require investment and concerted effort on the logistical side of things. I think hygienists are the ones that can be those primary care providers. I think we're starting to see some overlap in the other areas. Dental sleep medicine. So we know that airway is a huge issue with sleep apnea, and we're getting more and more awareness of how dangerous sleep apnea is to overall health. So sleep apnea is something where dentistry is starting to kind of take a step into, with sometimes oral appliances for folks that aren't compliant or can't be compliant with CPAP machines, or in addition to sleep apnea machines. Developing the airway, there's something called orofacial myofunctional therapy, where we know those narrow palates and those tongue posture issues that are a result of our environments and our diets are creating narrow airways. We are starting to offer services to help kids as they're younger, and adults even after they have kind of developed a narrow airway posture. But really, dentistry should be taking more blood pressures, referring more often, doing more health screenings, salivary diagnostics. There's lots of things we can do if we had the resources and the structures and the economies to do them.
I can actually share a personal example regarding comorbidities and what you just mentioned with the airway. So I was at the dentist and saw an image of my airway and said, "Oh my gosh!" Even as a physician with few symptoms, I said, "I think I should go and get a sleep study." So there's definitely multiple coexisting conditions, and for many patients, it might be the dentist they're seeing. Again, unfortunately, not the dentist for prevention, but for treatment. But in so doing, learn about other comorbidities. And so I think that communication with primary care providers and the dentists is very important and definitely growing, especially with the increase in obesity in this country. So, go ahead.
Again, the more we learn and the more technology is putting this information in front of us, the more we see the need for this. I mean, it was generally thought that most sleep apnea patients look like me, but it turns out a lot of them look like you. We have, and the technologies are finding these things. Even, I'll use an example. I do a lot of TMJ work. So we have a imaging X-ray unit that basically gives us a CAT scan-like image. Well, we're finding calcifications in carotid arteries and things like that all the time. So we can be screeners for some very serious issues.
Yeah. So for clarification for the audience, a TMJ is a temporomandibular joint. All right. So if you could recreate our dental health system from ground up, focusing on prevention first, what would that look like?
Well, I would start with what does a primary care dental provider look like, and it shouldn't necessarily be a dentist. And I'm probably going to get in some hot water with some of my colleagues, but we have dentists that are going to school. They're coming out with $500, $600, $700,000 in student debt. And, they are focused on how they can derive an income to pay off that student debt. We're focusing on things like Botox therapy, aesthetics, veneers, those sorts of things. And all those things are good and fine. But we do have this huge population that is not getting served. So I think we need to rethink dentistry for dentists, and we need to rethink dentistry for hygienists. I would think about what a primary care dental provider looks like that works in tandem with a dentist and with somebody that does a lot of the the basic cleanings, the prophy procedures. Mm-hmm. And that team, I think, can be very much effective. The same way it's been effective on the restorative side of dentistry with the expanded function dental assistants. And I think also, if we think about how we can create these different levels of providers where people can ladder up and make a career out of it. Traditionally, dental assisting wasn't a career because it wasn't family sustaining income. So if we can take these folks that are coming out of these vocational schools and give them opportunities where they can kind of grow, I think we can definitely service our populations much better, but we can also have great economies, careers. I did some quick math on, as you know, I'm involved with developing dental programs at Central Penn College. So a $2 million investment to a dental clinic at Central Penn College that would be able to see patients, Medicaid patients, with the students that are training. You have a free clinic or a Medicaid clinic. That would produce, I think, over access to care over 30 years. The 30-year return on investment would produce access to care for 1.2 million Pennsylvanians. It would be over $2 billion in salary. Think about what that does to the economy and what that does to the incomes. It would be, we have many small businesses across the state, dental practitioners that are struggling because they don't have the workforce. So it'd be small business support for about 1,500 dental offices. So a $2 million investment to make that kind of economic and healthcare impact would be incredible. So I would start there, and then I would empower people to do more within the different levels and stop thinking about just dentist versus hygienist.
All right. Well, thank you so much. Well, any words of wisdom for more of the audience that's listening as a patient seeking dental care? Any words of wisdom for us?
Well, I think the key is home care. Whether you're talking about oral cancer, dental decay, periodontal disease, the thing is home care. Make sure you're brushing your teeth 2 or 3 times a day, making sure the diet is reasonable. There's a lot of debate out there right now about fluoride. Fluoride was credited by the CDC as one of the 10 great advancements in health of the 20th century. So fluoride is not a bad thing. There is controversy over fluoride in the water, fluoridated water, and I think that controversy comes from people not liking the idea that they don't have the choice. So forget about fluoride in the water. Make sure you're using a fluoride toothpaste, or if you're going to the dentist, getting those fluoride treatments. That is not the controversial part. That's not the fluoride that you're ingesting. That's the fluoride that's mineralizing the teeth, and it makes a remarkable difference as far as decay.
Thank you. It's truly been a pleasure speaking with you today.
Thank you.
To the audience, thank you for being a part of this conversation. Please follow us on Healthy and Helpful Podcast on YouTube, Instagram, and Facebook. We look forward to having you join us for the next episode. Until then, be well.